From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. You're listening to JAMA Clinical Reviews. Thanks for joining us. I am Dr. Ann Cappola, Senior Editor at JAMA, Professor of Medicine at the Perelman School of Medicine at the University of Pennsylvania, and Director of the Penn Medical Communication Research Institute. Joining me today is Dr. Angela Fagerlin, who is Professor and Chair of the Department of Population Health Sciences at the Spencer Fox Eccles School of Medicine at the University of Utah and Salt Lake City Veterans Affairs Medical Center. We will be discussing her piece from JAMA's Communicating Medicine series titled How to Communicate Medical Numbers. Welcome, Angie.
Thank you so much for having me today.
Let's start with the underlying premise of the article. How can communicating numbers well with patients help us support their understanding, and how can communicating numbers poorly cause harm?
So my goal in doing this kind of work is really to help patients make more informed decisions. So a lot of when we're talking about numbers today, it's really going to be in the cases when we're trying to help patients make decisions. So I want to think about it in that context. When I give advice here, it's about when we're trying to inform patients. We might use different strategies when we're trying to persuade patients. So in that context, the examples I want to give today is when we're trying to get patients to make informed decisions rather than persuade, if that makes sense. So let me give you some examples in that realm. So when we're talking about patients who are making decisions, I'll say, for example, in breast cancer or prostate cancer, one of the things that I've heard from patients in those areas, they'll say, oh, the most important thing to me is to increase my likelihood of survival. But then when we look at the decisions that they make, we're seeing that they're making decisions that are actually decreasing their likelihood of survival. The treatments that they actually chose actually were the treatments that were most likely to lead to an earlier death. Or they might say, oh, the most important thing is to avoid erectile dysfunction. And then they chose the treatment that had the highest likelihood of erectile dysfunction. In those cases, I think one of the problems was that they didn't understand the numbers. And so those are the cases where I think we see that people are misunderstanding the numbers, and then they're making decisions that actually contradict what they say is most important in their decisions.
That's great. So let's move on to your specific recommendations that are evidence-based to help us do a better job of communicating numbers with our patients. Let's go through them one by one. You have 5 of them. Your first recommendation is numbers, even approximate, should be used to describe risk probabilities. Can you explain what you mean by that?
Yes, a lot of times what we see happen is that clinicians are using words to explain the risks or benefits of something. That's a low risk. That's a common risk. That's a high risk. And what happens in that case is people don't really understand what that means or what their definition of a common risk is, or a high risk could be very different than what the clinician actually means. And that can cause a lot of problems. So for example, when a clinician might say, oh, that's a high risk of something happening, what they might be meaning is like, oh, a 1 or 2% chance of a side effect or a 4 or 5% chance. But a patient might be thinking, oh, a high risk, that could be like a 25 or 30% chance of a risk. I am not going to take that kind of risk. And so I'm not going to do that procedure, or I'm not going to take that medication. And so what we're recommending is that clinicians really try to use actual numbers, because patients may be defining a common risk or a high risk very differently than the clinician.
Great. Are there ever situations where it's better to use words than numbers?
I think when we're trying to inform patients and letting them make a decision that's best for them, and we really want them to make an informed decision, I don't think there are a lot of cases where we wouldn't want to give people the numbers. But in cases when we're trying to persuade patients, maybe, for example, when we're trying to get them to engage in cancer screening behaviors, then that might be an example of a case where we might want to use words. But I think in cases where we're really trying to let them make an informed decision and let them weigh the risks and benefits of treatment, then I think it's probably best to use numbers in those cases.
The second recommendation is consistent risk denominators should be used when discussing numerical data with patients instead of a 1 in X format where the denominator varies while the numerator is fixed at 1. Can you give us examples of the 1 in X format and the preferred format?
Yeah, let me actually give you a personal example. I had all three of my kids in my 30s, so I got to have the joy of meeting with a genetic counselor all three times. And it was a very actually helpful experience. But one of the things that happened every single time is they gave me the risk of having a child with trisomy 21. So for my first child, my risk was 1 in 1,248. My second child is 1 in 314. And for my third child is 1 in 162. But that's really hard information to process, right? It's kind of in isolation of what does that mean? And actually, one of the things that to me is concerning as somebody who does work in this area is that the risk of 1 in 1,248 might seem to be the most at risk because it's the highest number, even though actually it's less risky. Because for some people, it might seem the higher number means it's higher risk. Another example is if you tell a patient that their risk of side effect A is 1 in 10, their risk of side effect B is 1 in 25, and the benefit is 75 out of 100. And the idea is like, that's really simple. It's 1 out of this, 1 out of that. And people just do the math to figure it out and make those comparisons. And we know from a bunch of studies is that, well, one, people most likely aren't going to take the time to do the math. And sadly, in many cases, people can't do the math. And so people are just going to be confused and they're not going to be able to understand and be able to make those comparisons if they're comparing several different drugs. And so what we recommend is to use the same denominator across all comparisons. So people can look at, okay, so everything's across a denominator of 100 or out of 1,000. And so that people can just look across all of them and see the same denominator and then be able to make those comparisons more easily.
Super. So we have to do the math for them.
Yes. Even if it's not as easy for us, it makes it easier for them.
All right. Your third recommendation is differences in probability generally should be presented using absolute differences instead of relative reduction or increases. Please tell us more about this recommendation.
Right. So again, not to tell you too many stories about myself, but let me give you another story. So it was one day I was sitting at work and my mom called me. This was about 25 years ago. My mom never called me at work, right? And she's like, Ange, I just read this thing on MSN and I'm really upset. It said that my risk of breast cancer is increased by 125% if I work second shift. And my mom at that time was a medical transcriptionist at this little tiny rural hospital. And she's not a morning person, just like I'm not. And she loved working 3 to 11. And she was going to change and go on first shift and be completely miserable because her risk of breast cancer would go up to 125%, which clearly was terrible if your risk of breast cancer increased 125%. Now, she didn't know what that baseline risk was. She didn't know what that risk increase was, but she was willing to make a horrible life change that would bring her unhappiness because that risk looked really bad. Right. And this is an example of just how powerful relative risk information can seem to people who don't understand risk information. When people don't have the absolute risk information, when they don't know what the baseline risk is, they don't know how to interpret that information. So if you have information and you say it's a 50% risk reduction, well, you don't know, is it reducing my risk from 50% to 25%, which is, hey, that's amazing. Sign me up. I want that kind of risk reduction. Or is it reducing your risk from 0.50 to 0.25? Well, maybe I don't want to do whatever I have to do to get that risk reduction. It makes it a very different kind of calculation for patients. And so we try to really encourage people to give people that absolute risk information because it's really hard to make an informed decision if you don't know what the change is.
Now, people are used to these relative reductions from marketing and all kinds of other situations. Is there a concern that we're going to sound clinically unimpressive when we give them the absolute risk reduction and not the relative risk reduction?
We might. And that goes back again to my earlier caveat when I started the conversation. Are we trying to persuade patients to do something? Sometimes we are, and sometimes that's perfectly acceptable. But a lot of times we really are trying to ask patients to make an informed decision of what's best for them. when they have to weigh these really important risks and benefits. And if we want to have patients make the decision that's best for them based on the risks and benefits and how they want to weigh those, then we should allow them to make those kind of decisions. And then sometimes I think we need to really think about, is a 1% difference that impressive, especially given the amount of work it might be for them to have to take a medication every day for the rest of their life, or the amount of money that they might have to pay to take that medication every day the rest of their lives, given the other kind of expenses that they have in their life. And so that's part of what patients have to weigh, and we should allow them to weigh those and maybe allow them to make those decisions, even if it's maybe a difficult thing to do. But then again, I'm a psychologist, so it's easy for me to say.
No, you've convinced me. We have to give the absolute risks. It's something we like to do at JAMA anyway in all of our publications. So hopefully you can find them in our work. All right, the fourth recommendation may be hard to explain without a visual. It is visual displays of probability should show both the numerator and the denominator in the ratio.
Yeah, this is where I wish it was a visual podcast. So one of the best ways to do that is what is often called a pictograph or an icon array. And what it is, imagine a graph of 100 restroom figures, like when you go to the bathroom and you see the picture of a male or a female. And it could be 100 of those pictures. Let's say you have 75 people who will benefit from a treatment, and you would color 75 of those in green. And then 25 of those are grayed out. So you can see 75 people benefit from them, but you can also see the 25 people who are not benefiting from them. So you can see the people who are affected and the people who are not affected. So you can see everybody versus just if you only presented the 75 green figures that just show the people that benefit from that.
Your final recommendation is contextual information should be provided for numbers that may be unfamiliar to patients. For example, biomarker levels. This has become a big issue with patients' ability to see all their test results, including all the highlighted H's and L's. How do you recommend we manage this?
Yeah, this is a really important question because, as you know, more and more people are getting onto their EHR, right? My chart, whatever, to look up their test results. Or their parents' test results, right? Or their loved ones' test results. And it's really important that we provide that context for them to interpret it. My co-author, Brian Zickman-Fisher, and he led this work over a decade ago to try to figure out how do we provide context for them? Because as we know, sometimes a low doesn't mean that it's actually that concerning. As you might know, as I was actually writing this paper, my father was very ill, and I was spending half my life on his electronic health record. And luckily for me, I have many mentees across all the different disciplines. I'm like, okay, so does this low who cares? Or does this low mean keep an eye on it? Or does this low mean call the SICU and find out right away what's going on here? And there's ways that we could make it more clear on the electronic health record to provide context of, is this a low that nobody cares about? Or is it the low that, okay, we need to keep on it. Hey, patient, you need to kind of try to do something, keep an eye on it, versus this is a low that you need to call your doctor. And this not only helps the patient kind of keep them calm, it also reduces the number of calls that doctors' offices are getting, the number of messages into my charts. Brian actually did a number of studies that actually showed ways in which we could communicate to patients the differences between, okay, yeah, this is a little out of range versus this is way out of range and deserves a phone call immediately to your clinician. And I think there's ways that we could do this better graphically that would benefit both patients and clinicians.
I absolutely agree. The number of messages we get over things like, low BUN or low ALT or my chloride or something like that, it would be really useful. Those reports were not originally designed for patients to see, and now that they see them, it does cause all kinds of problems. All right, any final thoughts before we conclude?
It is really difficult in this day and age to talk numbers to patients, right? Clinicians have a limited amount of time. Numbers aren't always easily available, but I think providing numbers to patients is a way to really bring patients in and allow them to make informed decisions. And so the reason we wrote this paper is we wanted to help clinicians to make this easier for patients to make informed decisions, because patients more and more want to be involved in these decisions and want to make the decision that is going to allow them to live the best lives for themselves. And in the end, it's the patient who is going to have to live with the consequence of the decision that is made for them. If they're involved in it or not, they're the one who is going to have to live with the consequence of the treatment that they're on or the treatment that they don't take. So anything we can do to provide them with the information that they need to make the best decision for them, I think, is really important.
Well, thank you so much. I am Dr. Ann Cappola, and I have been speaking with Dr. Angela Fagerlin about how to communicate medical numbers. You can find a link to the article in this episode's description. This episode was produced by Daniel Musizi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.